So let's talk about examination of the hip. We'll do a run through of the basic examination and then we'll look at some of the more finer points. First thing we need to do is expose the patient, so ask them to take off their trousers and get down to their underwear. As they're doing that, you can wash your hands and notice, are they moving comfortably? Have they got any walking sticks? Have they got built-up shoes? Any obvious rheumatoid changes in their hands? First thing we want to do then is inspection. So inspect it from the front. There's no obvious scars or any obvious swellings in the groin, no wasting of the quadriceps muscle. He's well aligned and his pelvis appears to be horizontal. Can you turn to the side now, please, sir? Looking from the side, normal lumbar lordosis. Again, no scars, no swelling, and his knee is straight. And can you face away? Similarly from behind, no gluteal wasting, no hamstring wasting, no scars, and his spine looks straight with no scoliosis. Clearly, it'd be nice if he was down to his underwear completely, but in an exam, I certainly wouldn't take off the patient's shorts, but just off the two. Good. Next thing we need to do now is Trendelenburg's test to test the hip abductors. Various ways of doing this. Simplest way is to palpate the anterior superior iliac spine and now ask him to stand. Can you stand on the left leg by bending your right knee? And the right side of the pelvis lifts off the ground, lifts up in the air, and that's a negative Trendelenburg test. Good. Now, can I see you go for a walk, please? So, assessment of his gait. You want to check his gait is symmetrical with a normal stance and swing phase. He has a heel strike and toe off, and there's no features of Trendelenburg gait or antalgic gait, drop foot gait, or a stiff hip gait. The next stage of the examination involves lying the patient on the couch. Really, you need to have the patient completely flat if you're going to do a proper examination. Obviously, some of the elderly patients struggle to lie completely flat. We'll just complete our inspection. Now that the patient's lying down, we can have a good close look. Again, just confirming that there's no scars or any swellings in the groin. Again, just double checking the wasting and looking from the side. You may sometimes see a small scar of a hip arthroscopy. The next thing I want to look at to complete inspection is leg length. So firstly, to measure leg length, to assess leg length, you simply put the feet together and note if there's any apparent leg length difference. The malleoli are at the same level, so there's no apparent leg length difference. Now, you can then go on and confirm whether there is any apparent difference with a tape measure, and you measure from a midline structure such as the umbilicus to the medial malleolus, 98 centimetres, and then to the other malleolus, 98 centimetres. So there's no apparent leg length difference. You probably ought to go on and then measure the true leg length, because the position of the hips, any deformities of the spine, they can all lead to a pelvic obliquity, and they can give you an apparent difference where there is no true difference. And to measure the true difference, first thing you need to do is make sure that the legs are in a symmetrical position. So check that the pelvis is level and that each leg is orientated perpendicular to that level. And then you measure from the anterior superior iliac spine to the medial malleolus, 95 centimetres, and then take that to the other side. That's 95 centimetres as well. So there's no true leg length difference. Now we move on to palpation. Now the hips are very deep-seated joints, so palpation's a little limited as to what you can discern, but certainly we should make some efforts to palpate the deeper structures. So palpating over the greater trochanter. Is that sore there? No. Okay. And then you can feel the anterior superior iliac spine quite easily, and then deep over the front of the hip in the midpoint of the inguinal ligament. And that's really all you need to do for routine palpation. Now we need to move on to movement, and the first part of movement is to do Thomas's test to look for a fixed flexion deformity of the hip. Various ways of doing that. The simplest way, I would think, would be to place your hand behind the patient's lumbar spine and to bend the opposite hip. So just bend this hip up for me, sir, and you bend the hip up until your hand is being squashed by his lumbar spine, and then looking at his left knee, it has not lifted off the bed, indicating that there's no fixed flexion deformity of the left hip, therefore Thomas's test is negative. Now we need to complete our movements. So flexion of the left hip, watching the patient for pain, is about 130 degrees. And then external rotation in flexion, 50 degrees. Internal rotation, 30 degrees. And take the leg down. And then abduction and adduction I find is easiest if you position the other leg over the edge of the couch to help stabilise the pelvis. Place your hand and forearm across the iliac spines and bring the hip out towards you. And as the pelvis starts to move there, the angle is about 50 degrees of abduction. Back to the midline and then across the midline. The pelvis is moving there. I can feel that. That's about 15 degrees of adduction. Now I perform a quick straight leg raise as a screening test for lumbar spine pathology. Is there any pain there, or is there just tightness?
No pain.
No pain. Tightness in your thigh?
Yes.
Okay, so hamstring tightness is normal beyond about 60 degrees. Final thing to do is neurovascular examination. So feel for a pulse. So that's the tibial pulse. The dorsalis pedis pulse. And then to check the neurology of the nerves which pass around the hip. So we're particularly interested in the sciatic nerve. So the peroneal part does the sensation to the dorsum of the foot. You feel that there?
Yes.
Same both sides?
Yes.
And the power for that nerve is toe extension. So pull your toes up towards your head, hold it there. That's normal power. And then the tibial part of the sciatic nerve is the sensation to the sole of the foot. Sensation the same both sides?
Yes.
And then flexion of the toes and ankle. So push down with your toes on this side, and that's normal. And for completeness, we should probably just have a quick check of the femoral nerve. So we'll just check the power in quadriceps. So hold your leg there, sir, and don't let me bend your knee now. And he has full power in quadriceps. So that's the basic examination done. I want to introduce Mr. Steve Crickler now. He's one of our hip surgeons here. He's also an examiner. Now, Steve, you've seen how I've examined the hip joint there. Just want to sort of see if you can, any different perspectives on it, things that you would do differently.
Okay, well, I think that was an excellent demonstration of how to examine a hip, and you covered everything that needs covering. There are a few subtle things that you might want to think about or people might like to do differently. Let's start with the Trendelenburg test. Can I stand you up? There are some patients who will be a little bit unsteady on their feet. I think if they're starting to wobble anyway, then it makes sense to try and support them. So the way I do a Trendelenburg test is I palpate for the pelvis and then I say to the patient, rest your hands on my forearms. And that way the patient is now steadying themselves. And then it's important, if I'm testing his right hip, I'll ask him to lift his left foot off, but patients will tend, if you say lift your left leg up, they'll tend to do this. There's a risk of personal injury to me if we do that, and it's not such a good test for Trendelenburg problems because the iliopsoas muscle, which is coming off the lumbar spine, can help hitch your pelvis up as you flex your hip, but you want to see if the pelvis dips. So it's important to keep the hip extended and just flex the knee. So, feeling the pelvis, rest your hands on my forearms, and now I want you to stand on your right leg and bend your left knee so that you put your left foot behind you, like this. And often if I demonstrate to the patient what I want them to do, they'll find it easier. And then the other thing I'm doing is I'm keeping John standing like this for a while. They say a delayed test is maybe 60 seconds, so that if the patient has a stable hip but rather weak abductors, thank you, you can put your foot down. If their abductors are weak, then initially they'll be able to stand, but after a few seconds it'll tire and you'll feel the pelvis beginning to sag. So that's the Trendelenburg test.
So, well, one of the subjects of Trendelenburg, let's talk about gaits. Now, do you want to demonstrate a Trendelenburg gait, explain why people get one?
If my right hip is painful or unstable, or I have weak abductors for any reason, post-operative surgery, nerve damage, whatever, then as I stand, my normal gait pattern is to lift my pelvis in order to help the swing phase on the left leg. So as I stand, go into stance phase on the right, swing through, I lift my pelvis. But if I've got an unstable or painful or weak hip, abductors, then as I stand on this leg, the pelvis will tend to dip. So you'll see my pelvis with the Trendelenburg gait dip with each step. Now, normally what will then tend to happen is you'll fall over that way. So in order not to fall, in order to keep your balance better, and also in order to offload the excess load on the right hip, you tend to throw your shoulders over to the right. So a typical full-blown classical Trendelenburg gait is like that, and the pelvis dips and the patient leans over as they walk. So like this.
Okay. Okay. So it's either an excessive sway or a sagging of the pelvis, or a combination of the two. Okay, great. While we're on the subject of gaits, other gaits around the hip. Antalgic's the
antalgic
common
gait,
one, isn't
you'll
it?
tend to have a short stance phase, so you'll be walking like that. That's a pain-relieving gait, so whether you've got a stone in your shoe, or a blister on your foot, or a painful knee, or a painful hip, you'll shorten the stance phase on the painful side and prolong the stance phase on the unaffected side.
Okay, fine, good. What about leg length? Let's expand a bit on the leg length measurement.
Now, leg length is something that a lot of people seem to get very confused about. There is this standard teaching by rote that you demonstrated very nicely, that if it's true leg length discrepancy, you measure it from that side. So you measure from the anterior superior iliac spine to the medial malleolus, whereas if it's an apparent discrepancy, you have to go from the midline. Let's just step back a little and try and understand what we're talking about. Can I lie you down, John? If John had a congenitally short right femur or tibia, or had had previous trauma and for some reason had a change in the length of the bony skeleton, then he would have a true leg length discrepancy. If he had a short right femur from previous fracture, the right leg would be truly short. So you would pick that up very easily if he's lying with all his joints in a comparable position, so he's lying in a symmetric position from a joint point of view. You would then see, as you come to the foot of the bed here, that his medial malleoli are not symmetric. Now you have to check that his pelvis is perpendicular, the axis of the pelvis is perpendicular to the axis of the limbs, so that there isn't an apparent discrepancy, but then you pick up a true discrepancy. An apparent discrepancy, that means that all the skeleton, the skeleton's normal, there is no leg length discrepancy from the skeleton, and yet when you look at his feet, they're not lying next to each other, so there is an apparent leg length discrepancy. For example, if he had a fixed flexion deformity in the hip, so if we just flex his left hip up a little, if he's lying in this position, or a fixed flexion deformity in the knee, then the leg would adopt this position, and as I look down here, there is clearly a big discrepancy between the position of his medial malleoli. That's not because his skeleton is different, it's because there is an apparent shortening due to the posture. That's pretty obvious. A more subtle one would be if he had an adduction deformity. So if I abduct his right hip and adduct his left hip, keeping his pelvis in the same position, then again there's a significant discrepancy. And you can demonstrate that yourself. If I just tilt my pelvis, and I do this regularly in clinic when I'm explaining it to patients, if I stand with my pelvis tilted, my left foot is off the ground, my left leg appears to be short. It's not truly short, it's apparently short because of the position I'm holding my limbs. So if all the joints are symmetric, then I've taken out of the equation any apparent difference. If there's a difference, it has to be true. If he has a fixed flexion deformity on the left, as long as I mimic that accurately on the right, so that he's got the same, I'm giving him the same posture of his right hip and knee, then I can check, and if there's no difference, then he doesn't have a true discrepancy. All the difference that I measure at the beginning of my examination is due to the apparent discrepancy from the joint positions.
Okay, that's very clear. Can you say you identify there's a true difference between the two limbs? How can you locate where that difference is?
Okay, thank you very much. That comes on nicely to talking about Galeazzi's test. These are classic clinical tests. Galeazzi is one of the classic clinical tests. If I wanted to judge, if I've decided that John has a short right leg and it's a true shortening, but I want to know whether it's above or below the knee, so is it his tibia that's short or his femur that's short or both, then if I flex the knee to 90 degrees and I flex the other one to 90 degrees, and you just check the heels are now together here, and I've checked already that the pelvis is lying true on the examination couch, then by now sighting like this, I can see whether and you can actually do this with your hand, or you can do this with a piece of paper or the notes in clinic. If you put your hand here like this and your hand here like this, if the shortening is above the knee, then this side will drop back, and if the shortening is below the knee, this side will drop down, and my hand will either be in this position or both. If patients have a congenital shortening of a limb, they may have shortening in the femur and tibia, and you'll see it on both. So that's the first step, Galeazzi's test. And then classically, if the shortening is above the knee, the next question is it in the shaft of the femur or is it at the top end of the femur? And Richard showed that in the previous video. Part of the palpation, I'm old enough and lucky enough to have been on Alan Apley's course for as it then was, final FRCS for examining patients, or orthopaedic course for FRCS. Alan Apley had a very neat technique where you start palpating low and you bring your thumbs up and you come up to the anterior superior iliac spines. And you can come up because it's an overhanging structure, so you can feel you're pushing up onto the spines, and then you, having put your thumbs up against the anterior superior iliac spines, you feel above the trochanters with your fingers, and you start quite high up here and you work your way down and you get down to the top of the trochanter. And I can feel the top of both trochanters, and I can feel that my hands are in a symmetric position. Whereas if he had shortening on the left femur, if the shortening was in the shaft of the femur, I'd be in the same position. If the shortening was because of a congenital problem in the hip or a developmental problem in his hip with a dysplastic hip or a slipped epiphysis or previous femoral head injury or trauma or something, then I'd be feeling, and I'd end up with my hands in this position where my thumbs would be on the anterior superior iliac spines, but my fingers would be at a different height on the trochanters. And that's defining that piece of anatomy.
Okay, so that's just essentially variance on Bryant's triangle, which I have to say I've always found a difficult test to understand. I think that's excellent. Now you're in the perfect position now to demonstrate Thomas's test.
Okay.
Now we've explained Thomas's test is for a fixed flexion deformity. You've seen the way I do it. Any other ways?
The way you demonstrated it is a pretty standard way of doing Thomas's test. And if I were trying to assess a trainee to say, does he understand Thomas's test, that's fine. If you're really looking for it in a subtle way, let's say that I was worried about John's right hip, and I'm looking for Thomas's test on the left, in the right hip. I use the left hip, as you did. I'd flex the hip up. But I find it's a more subtle way of, doing Thomas's test is to start with this hip in flexion. So I put it comfortably there. That way this hip is relaxed. And then, as I bring this up, can you put your hands over your knee and pull your knee onto your chest? So I get the patient to lock their pelvis in a flex position, and I can feel he's lost his lumbar lordosis and he's holding his pelvis in flexion by maximally flexing the unaffected hip and holding it there. Now I'm going to lower this leg while you keep that leg up, and as you bring the leg down, will it go all the way? Okay, and obviously in John it does, but you'll pick up a subtle amount there of fixed flexion in the right hip, which I think you would miss if you started in this position with the hip in full extension. As you flex this hip, you'll think you've got to full flexion, but he's not taking the pelvis quite as far because he doesn't want to lift this leg off. So I find it's a more sensitive way of doing it, to start in flexion and go into extension.
Yeah, and I think as well, if someone's got a painful condition of one hip, to then crank the pelvis into a neutral position with the other hip can be very uncomfortable for the irritable hip. So what you've done there is you've given him the control of hip extension, haven't you?
Yes, and you can stop as soon as it begins to get uncomfortable. Yeah. But the point where it begins to get uncomfortable is the point where you're developing or you have a fixed flexion deformity.
Yeah. Let me demonstrate another technique. This is one thing that a lot of the students seem to want to do, and they sort of try and do both simultaneously. So they pop their hands behind the back here, and they bend up one hip fully, and they comment on the range of flexion of that hip, noting that the other knee hasn't lifted, and then they bring up this one, comment on the range of flexion of this one, and then they lower this one. And it's some sort of effort of doing Thomas's test and flexion on both legs at the same time. I think that's very cumbersome, not very elegant, perhaps not something to do in the exam. What do you think?
Yeah, I think if you have a patient who has a problem in one hip, then it's probably cleaner to move that hip and then leave it in flexion, flex the other hip up and put it down. If the patient has bilateral hip disease and you want to quickly assess what the range of flexion and extension and so on is in both, I think it's not unreasonable to flex both hips fully and compare the two, lower one, lower the other. But it is, it's a more clumsy way of doing it if you're trying to look for a problem on one hip.
Okay. So we've covered the range of movement in our previous section. In terms of measuring hip extension, in terms of rotation and extension, personally I don't think that's worth doing unless someone's asked you to do it. I don't know what you would think about that.
I think if you've measured rotation in flexion, I don't think there's an awful lot to be gained by measuring the extension as well. It can be done. It might be worth commenting that it is possible, but there aren't many conditions that you pick up significant pathology in one without the other.
Although, femoral anteversion. Now, how would you assess femoral anteversion? Because that does involve rotation
that is
and
important.
extension.
This is really a test which is typically used in a paediatric setting when you want to assess a child and measure their femoral neck version. It can actually be quite useful in an adult, particularly if there's a history of dislocation of a total hip replacement, and you want to try and clinically assess whether you think the femoral or acetabular or both components are malpositioned. Can I ask you to roll over on your front, please? What you're trying to do is to feel where the trochanter is. If anybody's ever tried to set timing on an engine and you've tried to determine top dead center of a piston head in a cylinder, it's the same sort of thing. If you don't know what I'm talking about, let me show you. As I move his foot like this, I can feel the trochanter moving under my right hand. So what I'm feeling, my hand's here and the trochanter is rolling like that. And what the trochanter is centered on is obviously the center of the femoral head, the center of the hip joint. So if you think the head is here, the neck is here, and the trochanter's there, as I'm doing this, there comes a point when the trochanter is maximally lateralized. And at that point, the femoral neck is horizontal. So if I do that with John, I can feel that point is just about there. And Richard, now standing at the foot of the table, can say that that's, what, 20 degrees?
Yeah, 15, 20 degrees.
15, 20 degrees. So John's tibia is about 15 degrees from vertical. That's vertical, that's 15 degrees. And as I put him in that position, I can feel the trochanter coming out maximal laterally.
That's internal rotation. It can be quite confusing when they're prone, that you get your internals and externals backwards. So that's 15 degrees of internal rotation.
Yeah, the anterior surface of the femur is rolling inwards, and that means that the neck must be pointing anteriorly slightly. As I bring the tibia vertical, the femoral neck is now pointing more forwards.
Good, excellent.
And then I'd obviously do the same on the other side, and you can compare, in a normal patient, you can compare the sides, and as I say, this works in a patient who's had a total hip replacement, and you're not sure what the version of the femoral component, you can measure that quite easily.
Yeah, good. John, roll over for us. Just a couple of quick tests that I think we ought to mention. Impingement testing is something that we hear a lot about nowadays.
Yeah.
Do you want to explain how you do that and why you would do it?
Well, impingement is now becoming a very topical clinical diagnosis. The typical impingement is anterior femoroacetabular impingement, and you get it maximally, just relax, let it come up, you get it maximally in flexion, adduction, and internal rotation. So if you push the patient into that position, and you can say, the pain you've been telling me about, as I put your hip into this position and move it, does that reproduce the pain? Is that the painful feeling you've been getting? And that's a standard test for anterior femoroacetabular impingement.
Okay. And I think perhaps another test we ought to just finally mention is the Faber's test, yes, where we flex, abduct and externally rotate. So it's a similar sort of thing, but this is a test for SI joint pathology and hip pain. So by stressing the hip into external rotation and abduction, while maintaining pressure on the opposite iliac crest. If that produces pain around the back, that indicates his SI joint's the source of the problem. If it indicates pain in the hip, then that isolates the hip as the probable source of the problem. I think that's everything. Thanks very much.
It's a pleasure. I hope it's been helpful.